much, Nicolas, for your kind invitation. Thank you, Raphael and Huda, that you give us time and a spot to present here data also from the endocrinology part. And I will start. Emanuel will take over. We work very closely together, and that's also why we present the talk together. So the endocrine consequences of pharyngioma treatment from childhood to adulthood. You know these axes. This is the very simple world of an endocrinologist compared to neurologists and all other disciplines. We just have to look for 6 axes up and down. That's all. What is important in this field and what I would like to stress is if you have here a damage, then you have possibly deficiencies in all these axes. The central diabetes insipidus, hypothalamic growth hormone deficiency, central hypothyroidism, and central hypocortisolism. So, but which are really dangerous and can make problems where you should be really prepared for are these 2. So, especially in the perioperative situation, you need to be prepared for the acute DI immediately hours after the operation and central hypocortisolism. So, diagnosed in childhood, I would like to start not only with the late consequences. For me, as a clinician, it's always important to think before already you have a diagnosis. And I think that's what I would like to start with, a little story about the girl. She was diagnosed, it's 15 years ago. She came to us with strabism, visual disturbances, and she had a short stature, or let's say a little deviation of the growth curve. The MRI showed cystic craniopharyngioma. You see here the MRI pictures, and what was going on. This is this typical or not for children with craniopharyngioma, which are the clinical signs which could lead to the diagnosis. You see here a paper from Taylor from Journal of Pediatrics. He looked at 180 pediatric patients, 32% craniopharyngiomas. And what they saw is, if you look and go back after diagnosis, retrospectively you have the neuro-ophthalmologic symptoms at the very end. But if you ask, you will see that there will be also diabetes insipidus, precocious puberty, and abnormal growth. And quite a long time ago, and especially for craniopharyngiomas, these growth disturbances can last not even 1.5 years, but rather 3 years, 4 years, because they are so slowly growing. And if we take away the hamartomas and the cysts, then precocious puberty falls away, and then you see these are typical signs what you can encounter, and which are quite obvious also for pediatricians. I always show this picture also in general pediatrics. So what are the numbers you can find if you have diagnostics in children? So about 2/3 to 85% will have visual signs, ophthalmologic problems. About 1/4 maximum will have diabetes insipidus, depending on what paper you read. You will have 3/3, 75% of abnormal growth. So abnormal growth is really the tip of an iceberg, and be prepared to look for that and take it seriously. So this was our patient, and it was decided at that time that in the first step in a large cystic tumor, the first approach would be just a decompression. You see what was down there. You know these pictures better and can be an endocrinologist, but the dimensions clearly went down and the pressure went away. So me as an endocrinologist, should I be, or an intensivist, should I be scared or prepared for any immediate endocrine problems after this surgery? Who thinks this would be the case? Nobody. Nobody dares, so everybody knows. I don't know, but it's correct. Here, of course, the risk is very low. But then, in a second step, 4 weeks later, at that time in 2007, there was a partial resection planned. You see here the pictures. Who thinks that now there could be any endocrinological problems? Should we be prepared for something or not? Please raise the hands. Okay, there are some hands and they are right, exactly. So here we need to be prepared, and it's a little bit like this when the neurosurgeons walk out, the endocrinologists come on the scene, or at least they don't take the scene, but they wait for the call from the intensivist. The sodium is rising, what should we do? It's typically 4 o'clock in the morning when the young assistants and the ward become nervous because they don't want to wait until 8 o'clock. So it's clear that in this case, we had a Panhypo. We treated it accordingly with the hormones. This was a typical situation. I would like to show this picture. You probably know all of this. This is also in the textbooks. This is the sodium postoperatively, serum, sodium, and urine output. And of course, the urine concentration in the inverse way. And here you have, of course, the first phase of DI, then SCADH, and then the chronic and definitive diabetes insipidus situation. You can treat, if you want, at the first phase. Here you need water restriction for the SCADH, and then again chronically for a long term. The younger the child, the more difficult it is to find the correct dose in children, and it's need to be titrated carefully. There are no standard doses, and the most important is don't start with high doses. You can induce an anuria for 3-4 days if you really are not careful. So another thing I would like to show you, think twice if you are on this side. This side is quite easy. This is central DI. You won't encounter a conflict. But on the hyponatremia, we always think it must be SCADH. So it's easy, we restrict water. But there is a second thing which is less known, rarer, but can be much more endangering. Look also on the volume clinically of the patient and the blood pressure. And of course, SCADH would be you or hypervolemic. But if you have hypovolemia and polyuria, think of cerebral salt wasting. I rather call it SCANP because this is the syndrome of inappropriate atrial natriuretic peptide. It's exactly the same mechanism as the SCADH. It's an inappropriate oversecretion of atrial natriuretic peptides, or also BNP, and it leads to natriuresis and lowers the volume and the blood pressure. So be prepared for this rarer complication, or that it kicks in even in parallel with SCADH or DI. Then we go on. The girl developed a recurrence 12 months after resection. You see here on the picture. And this was the first child we sent to Willigen for proton therapy in 2008. And then we have the following follow-up. The treatment with protons was very well tolerated. And you see we had the first treatment, the initial treatment, life-saving access. Then growth hormone, you should start in a pre-pubertal age if you can, of course. And the treatment at pubertal age for the gonadal axis, either estrogen or testosterone in boys. And if we look at here over the growth curve we had the diagnosis here. You see this was not a dramatical drop in growth rate, but nevertheless significant. And then we started growth hormone 2.5 years later. Well, here was the diagnosis, here was proton therapy, and 18 months after stable disease, we decided to start with the treatment. And then at 12 years, we started pubertal induction, and finally she reached her genetic target height of 1.69 m. Nicely. So this is the easy story of our patient, but what happens if you would have patients which are diagnosed much later? 12 years, 14 years, you start treatment, but you're not sure. When could we start with growth hormone therapy in this situation? And this is much more of a conflict. A lot of discussion has been done. And I think who would start here within the first 12 months after treatment? Please raise your hands. Okay, they are the neurosurgeons of Basel. Very good.
Question before, with or without prostatic resection, or There is no relation between the quality of resection or
no, independently of what was done. Yes. Then who would, from 12 months on, who would start to treat, who's afraid, and who would like to wait 2 years to be on the very safe side that growth hormone doesn't do anything on the residual tumor. So you need to see, this is safety, and now you need to see what we can achieve with these treatment delays. So if we are here, we have the diagnosis, we have 1 year after treatment, we start the treatment, we will probably get her in genetic target. If we wait more than 1 year, 2 years, it will be, well, not sure. And if you wait long, then you really will get in trouble. It's a question of is this a trouble or not, but it's one part of quality of life if you are too small as a consequence of growth hormone, of a craniopharyngioma. And this was a long time a discussion, and I'm very happy to present you now the consensus statement which came out now in January. Also, Professor Miller was part of this consensus statement, but about 40 international experts on growth hormone, and clearly everybody says that initiation of GH therapy needs to be individualized, but read this. This period may be as early to start growth hormone therapy as 3 months in children with radiologically proven stable craniopharyngiomas who have significant growth failure and metabolic disability. So I think this is an important message. It doesn't mean that you need to start immediately with growth hormone, but you don't need to be too much afraid to start growth hormone, especially in children where you know the door is closing, the time is moving, and you risk to have, at the end, a child who's too small. And this will have also impact on quality of life. And there is no evidence that this growth hormone therapy will induce the recurrence of the tumor itself or secondary tumors in the context of all treatments. And this consensus statement, I think this is one of the most important messages from today for me. And these patients doesn't need to be treated in another way than other patients with growth hormone deficiency. Simply watch them closer and watch the IGF levels to be sure you're in a safe level, and then it should be okay. The final thing is hypothalamic obesity can occur. This is the weight chart of our girl. You see, she developed obesity, came back again, and the obesity didn't start after the operation. She was stable. So this is not a typical obesity curve. This is rather an obesity after a certain depression, also in the consequence of her whole disease, but she managed with conservative diet to get back again. If we would have a patient with hypothalamic obesity, what are the other possibilities? Well, in pediatrics, it's difficult. In adult patients, it's much easier. We have now a new group of treatments, GLP-1 receptor agonists. They increase insulin sensitivity, satiety, and they reduce the speed of grass through emptying. And just now came out the first randomized control trial in craniopharyngioma patients, 10 to 26 years. A small study, but nevertheless the first randomized control study beside a couple of case reports and little studies. And they show a certain effect. So I think this could be something. After that, we have already evidence in the adults to improve this situation and treat them. And this is the first data on 10 years old compared to the other literature. So I come to an end with the take-home messages. These are the pictures you know. I would like to add that there is cerebral salt wasting and look at the volume in patients at the ICU. Here you know how the sequence of the hormone replacement. And I would like to show you this picture, so don't be afraid to discuss growth hormone early. And finally, there's this new group of drugs that might be very interesting also in the pediatric age group. And now I hand over to Emanuel, who will continue with the situation in adults.
Thank you very much. Thank you to the organizer that an adult endocrinologist can be here as well. So I have to look. Okay. I think the easiest way to go to the adulthood is just to go through a history of a patient then, because the history of the patient, for me, it tells most of the story. So this was a 34-year-old female. Leading symptom was secondary amenorrhea. And when she came, she was at least 1 year secondary amenorrhea. MRI suspicion craniopharyngioma, partially cystic, suprasellar extension. Other past history was unremarkable. She was just divorced, and there was no fertility reproduction issue for the time being, no partner. Cardiovascular risk factor, this is new. These are the pediatric, are a little bit less used to ask for that. So nicotine, dyslipidemia. Osteodensitometry, we always perform that when there is a significant amenorrhea before diagnosis. So we perform osteodensitometry, and this was normal. This was her cranipharyngioma. A picture, partially cystic. You know that better than me. And she had an operation, transcranial frontotemporal with subtotal resection. And this was the histological bit. And obviously, as we saw before, she was panhypopit, without big problems perioperatively. And now she was otherwise fine. She was replaced, and she had a progression already 2 years afterwards. And then you see that. And this is the sagittal. And she had cyberknife treatment. And with that, again, she was fine for nearly 10 years. Stable disease, yearly MRIs. And then she had again a solid progression, cystic and solid remnants. And then implantation of seeds locally and punction of the cysts. So this was the brachytherapy Alessia showed before. And this was before, and this was afterwards, and she was stable again, including visual fields. Now, this is what she had. Weight gain, 90 kilograms in 15 years, progressive, and this is well in line with our published data from all craniopharyngioma. These are between 30 and 40 craniopharyngioma. You see that this is the last follow-up, mean at least 10 years, and this is baseline, and you can see obese, green, overweight, pink, normal, black, and the black bit is very small, only 20%. All the remaining are really overweight or obese. This is really a very important point. She had replacement therapy. You know, this is quite a high dose. Obviously, this was FT4 was within normal range, but upper limit of normal range, hydrocortisone, minurine, and transdermal estrogen. We prefer transdermal estrogen, especially because she was prone for thrombosis. And then you do not want to have the oral replacement therapy. And you immediately see that's the pediatric, they are not used to that, so she had cardiovascular risk. Rosuvastatin, statins, she had for the bone, and she had, because of repetitive thrombosis, she had Xarelto. And then you immediately see an antidepressant as well. You can certainly think the quality of life was certainly impaired. The cardiovascular risk factor, persistent, smoking, normal blood pressure, no diabetes. If you go now to all the bits and pieces in the long-term follow-up of craniopharyngioma, this is Karavitaki from Birmingham. She was in Oxford before. You can see obesity, panhypopit, regulation of free water, feeling of thirst. She had that. She did not have sleep apnea. She had transitory neurological problems postoperatively, but not persistent. Cognitive function, not really, but she had severely impaired quality of life, leading to incapacity to work. She was really she was not capable to work anymore as an assistant nurse. The teaching point, I think when we go to the perspective of our profession, this is a rare disease. There is no clear evidence for treatment always. We need experience. We need different therapeutical modalities. We have seen all the radiotherapy, the possibility we have. And we need a dedicated interdisciplinary Pt.3 board. From the patient's perspective, and I think this is extremely important, we have to tell him that he needs, and I do that always at the very, very beginning, you need to have a lifelong follow-up. Also to adjust to replacement therapy, a lifelong replacement therapy, and there is a possibility for remnants or recurrence. Chronic fatigue, incapacity to work, and social isolation is not rare in this disease. This is really one thing we need to take in account. And what in my experience is very important, we have to tell that at the very beginning, within the first year, not immediately before the surgery, not immediately after surgery, but within the first year. The lifelong follow-up, imaging, lifelong replacement therapy, weight and appetite issue. We have to discuss that. I have very good follow-up with a patient who started to do a lot of sports immediately after the craniopharyngioma treatment. And when you tell them the weight is not your fault, it is part of the disease. But unfortunately, we do not have a miracle drug. Be careful and eat 3 times a day, not 5 times. But it is part of the disease, and we have to tell them that very early in the course. The other thing is the reproduction fertility issues. This was not a problem in her case, but personally, I tell the patients within the first year, when they are young, even when this is not an issue, only fertility may be an issue. We can help you, but tell me when this is an issue for you, because you will need help. And for instance, in males, I experienced a situation where males came to my clinic. They wanted to have children, and they were still on testosterone. And obviously, you need to switch to gonadotropin, but they were not aware that they are not fertile. So, and if you tell them at the very beginning of the disease, within the first year, when you want to have a family, let me know, we help you, but you will need help. What do we have to expect? And always when I'm talking about mortality, this is Breuchel's picture from Prada, from Madrid, der Tod, the death. The standard mortality rate in adulthood is increased 3 to 9 times, depending what you have and how big it is. Mainly cerebrovascular disease and cardiovascular disease. This is associated, cerebrovascular disease is associated with the toxicity of very often operation and radiation. And the cardiovascular in general, because of obesity and metabolic disturbance. Treat cardiovascular risk factor aggressively. This is a key message. What I do, and you have seen that she had statins. I tried every time to keep her off the smoking, but that was not successful so far. And with that, thank you for attention. I'm happy to do this.
Thank you very much to both of you, Emanuel and Gabor. I think it was very, very interesting. It's always good to bring patient cases because we learn a little, we learn very much It's emotional, so really, I think this emotional memory is important to learn. Thank you very much for this demonstration. Perhaps we have some time for one or two questions. As a pediatrician, if I may start, you said there is not the miracle pill against obesity. Gabor brought some, perhaps, small light in the system. As a pediatrician, I was asking myself about bariatric surgery. Do you have patients who are going that way? It is correct, it is dangerous. What is your experience?
No, but there are French data. The French, they do bariatric surgery sometimes in hypothalamic obesity. They do that. I don't have bad experience. But the pediatric patient is a little bit reluctant to do bariatric surgery at the long run. So, but
in the adults. So perhaps 5 to 10 years after.
In adults, I don't know a big series, must say. But I could imagine that it works. The problem is the GLP analogs, they have receptor in the hypothalamic, and some of the effect is mediated probably centrally. And if there is hypothalamic craniopharyngioma, and this was my experience when I used these GLP-1 analogs in some of my patients with hypothalamic disease, they were not extremely efficient. So you need the receptors as well.
Yes. Is there any data on mortality from central DI in children and adults?
We have published just recently from official claim data from Switzerland between 2012 and 2018. Mortality data, hospital length of hospital stay, rehospitalization of hypopit patient compared to matched control without DI, without hypopit. So, for instance, one patient, 55 old, myocardial infarction without hypopit, 55 with hypopit. And what came out is hypopit is really associated with increased mortality, increased length of stay. But these are only inpatient data, and the mortality is mainly associated with the DI, not with the corticosteroid. So yes, for inpatient we have the data, for outpatient I'm not aware of. The best data is probably the KIMS data. There's one study by Wolf Gaillard who pretend that diabetes insipidus is a risk factor for mortality. Yes,
maybe more curiosity to Gabor. The question is how difficult it is to titrate the growth hormone therapy in children, depending on the age where you make the diagnosis or you want to start your substitution.
That's a good question. It's not that difficult. Mm-hmm. I mean, in these patients we treat together with Nicolas and you, we always start at the lowest dose and then we see where we get, and then we slowly can titrate the IGF-1 in a level where we say, okay, this is safe, but we do not overshoot. So this is, we control very strictly. Every 3 months the IGF-1, and the others we can do it every 6 months. That's enough. But titrating growth hormone is not that difficult compared to mini ring, which is very individual, necessary, and especially in the small kids, as I told you. That's sometimes quite a challenge, also because the nose is not resorbing the same way. So the DI is difficult, growth hormone is easy.
Another remarkable question, actually, I'm not a pediatrician, but I thought it was so trivial, actually, to check on the growth of the children in the daily management of pediatricians, and so do not they put children systematically on growth curves, or their parents don't? Is there any education on that?
That is a very good point. I have a graph with different growth curves, and then I show also with the red, green, and yellow, because you always start green. And at the beginning, if you change just 1 percentile, this is yellow. But if you don't get back and go further than 1 percentile, then it's red. And you need to see the kids. And the other thing is, at the beginning, the pediatrician sees them, you know, every 2 months and then half a year. And then in the critical time point, when craniopharyngioma shows up, let's say between 8 and 16, the frequency of visits with pediatrician are very low.
They don't want to see the doctor anymore.
Exactly. Or the parents say, well, this is okay. So this is a bias which adds on. And the second thing is, yes, we need to have a sharp eye on this growth curve to react. And this is now much, let's say, much more present than maybe 20 years ago, where this was, well, it's just growth and you will catch up. And now the sensibility is much more.
I wanted to ask also about the growth hormone, because we have had like endless discussions on when to start, right?
Exactly.
And now you show us the new guidelines that you can start as soon as 3 months after, stable. But when is stable, right? And when you start? So maybe you elaborate again on this. And do we have to change our surveillance protocol, imaging protocol?
Well, I think this is so new, we will discuss that together, but we have exactly these cases where we discussed, and do we need to wait? Can we start? Should we add proton therapy to be very sure before we start, and all these things? So I think this message, and this is very broad, these are really the people who are able to give us a good answer for that. And it's encouraging, and I'm happy that we have that, because before there was not that much of such a good guideline to follow. And I think this is what I would like to present today. You need to discuss individually and with the parents and pros and cons. And if the child is 5-year-old, you don't need to start at 3 months, of course. And in our case, you saw the growth curve was not dramatically deep. So there we wait. But if you have, as we had recently, a boy of 14 years, and the treatment then is 15, then the time is short to catch up, especially if you're very low. And then you need to discuss together what is security, what is growth, what is quality of life, how important is that for the patient. And then you try to find a good thing, but a good decision. But I think we don't need to be that afraid as for other tumors, like we discuss always together. And I think you need to read this. You need to read these guidelines, because they are not just for craniopharyngioma, they're for all intracranial tumors. And the craniopharyngioma is the best, you can start earliest. For the others, there are also nice numbers and guidelines, but it's very good to have the possibility that we don't need to wait 2 years to cure this. We can start earlier. In cases we...
Okay, thank you very much. Last question?
Yeah, to Emanuel. I wanted to ask if you comment on the general opinion that for us neurosurgeons, maybe losing the whole control hormone function in a patient is acceptable. But what do you think about the data that patient groups that need full substitution for their whole life, their life expectancy is less? And what is this based on? Is it the cardiovascular, as you showed, craniopharyngioma, or in general population that needs full substitution? Should we not underestimate the consequences in long term?
Panhypopituitarism is still associated with increased mortality. Standard mortality rates, there are numerous, about 10 papers, 2 meta-analyses who show that. But the encouraging point is there are also 2 or 3 papers who have a time course of mortality. So patient treated before 2000, patient treated after, and standard mortality rate goes down, approaching, for instance, non-functioning pituitary in adults and normal standard mortality rate, also in acromegaly. So we become better. This is the message. But still, overall, panhypopituitarism is associated with increased, mainly cerebral and cardiovascular disease. The reason probably it's extremely difficult to tease out, because some are partial dysfunction, some are complete. But the main thing is all are slightly overweight, panhypopituitarism. This may be because they don't have growth hormone in adulthood, or they have too much hydrocortisol, or there are different reasons, or they have hypothalamic disease as well. So there are different reasons, but most of them are BMI between 25 and 30. And they have the accordingly blood pressure, insulin resistance, etc. So yes, they have, but will be coming back.
I think we can close the session on this optimistic view. Thank you very much. I'd like to thank again all the four excellent speakers that we had.